EPS approach to narrow complex tachycardia. Indications for electrophysiological studies, EPS, in narrow complex tachycardia, NCT. 1. NCT resistant to treatment, to help identify the mechanism of arrhythmia, and study the reentry circuit. 2. Bypass tract, BT, suspected to be life-threatening. 3. Some authorities advise EPS for any BT with symptomatic tachyarrhythmia. 4. Others even advise EPS for any patient having BT. 5. When catheter ablation is recommended. It is of note that no two electrophysiological studies for supraventricular tachyarrhythmia are the same. During these studies, unpredictable findings are commonplace. The electrophysiologist must, therefore, be alert and ready to modify his study plan as required. General rules of EPS for NCT. Better start by ventricular pacing, to avoid early induction of atrial fibrillation, which will complicate matters. During ventricular pacing, retrograde conduction, ventriculotrial, VA, interval, VA refractory period, and pattern of atrial activation are studied. Followed by high right atrial pacing, with the study of sinoatrial and atrioventricular node functions. Followed by coronary sinus pacing, particularly to look for the presence of a left-sided bypass tract. Differentiation during EPS. To differentiate between the three types of paroxysmal supraventricular tachycardia, SVT, atrioventricular node reentrant tachycardia, AVNRT, atrioventricular reentrant tachycardia, AVRT, and atrial tachycardia, AT, you need to answer three questions. 1. What is the mode of induction of tachycardia? 2. Is atrial and ventricular myocardium necessary for the tachycardia to continue? 3. What are the effects of drugs and autonomic maneuvers on the tachycardia? The first question is discussed in this lecture. Q1. What is the mode of induction of the tachycardia? Which arrhythmia can be induced? As discussed earlier, two types of arrhythmia can be induced and terminated by programmed electrical stimulation, reentry arrhythmia and triggered arrhythmia due to delayed after depolarizations. Two other types of arrhythmia are neither induced nor terminated by programmed electrical stimulation, automatic arrhythmia, and triggered arrhythmia due to early after depolarizations. Conclusion. If SVT is induced, inducible arrhythmias are all possible, while non-inducible arrhythmias are excluded. If SVT is non-inducible, non-inducible arrhythmias are more likely, while inducible arrhythmias cannot be excluded. Tachycardia zone. The tachycardia zone is the range of coupling intervals over which premature beats can induce reentry tachycardia. Premature beats are introduced with progressively shorter coupling intervals, until reentry occurs due to block of the premature beat in the beta pathway. This is the start of the tachycardia zone. Further introduction of premature beats, with shorter and shorter coupling intervals, will continue to induce reentry until the impulse also blocks in the alpha pathway, and reentry cannot be induced. This is the end of the tachycardia zone. Left, premature beats are introduced with progressively shorter coupling intervals, until reentry occurs due to block of the premature beat in the beta pathway. This is the start of the tachycardia zone. Right, further introduction of premature beats, with shorter and shorter coupling intervals, will continue to induce reentry until the impulse also blocks in the alpha pathway, and reentry cannot be induced. This is the end of the tachycardia zone. Induction site. Define if a tachycardia is easier to induce from a particular site, for example. If SVT is readily inducible by ventricular pacing, it is most probably AVRT, because the ventricular tissue is part of the circuit, much less likely AVNRT and rarely AT. If SVT is easier to induce from one atrium than the other, comparing high right atrial and coronary sinus channels, it suggests the presence of a bypass tract at that side. Why AVNRT is difficult to induce by ventricular stimulation. With ventricular stimulation, the impulse conducts up in both the alpha and beta pathways, but more rapid in the beta pathway. When it reaches the alpha pathway retrograde, it finds it refractory by the stimulus traveling upwards and cannot re-enter it, thus re-entry is not established. With ventricular stimulation, the impulse conducts up in both the alpha and beta pathways, but more rapid in the beta pathway. When it reaches the alpha pathway retrograde, it finds it refractory by the stimulus traveling upwards and cannot re-enter it, thus re-entry is not established. Rarely, if a ventricular extrastimulus is interpolated between two sinus beats, it may render the beta pathway refractory for the next sinus beat, and re-entry starts. If we suspect bypass tract pacing at different sites in the right atrium and coronary sinus is performed, the closer the pacing to the bypass tract, the more the pre-excitation. Isoproterenol infusion is used if arrhythmia is not induced. Induction of atrial fibrillation is tried, to assess the risk of rapid conduction in the bypass tract. Methods of induction of AVNRT and AVRT were discussed earlier. Induction of intra-atrial reentrant tachycardia requires intra-atrial conduction delay. The atrial extrastimulus used should be early enough, or the atrial pacing rate should be rapid enough, to produce enough intra-atrial conduction delay. At this moment, if the wavefront encounters unidirectional block in one pathway, but conducts in another pathway, re-entry is induced. This tachycardia is usually easy to induce with a wide range of coupling intervals. The initiating coupling interval, and the interval between the extrastimulus and the first beat of tachycardia, are inversely related. Induction of sinus node reentrant tachycardia. Sinus node reentrant tachycardia can be induced and terminated by atrial pacing, but does not require intra-atrial conduction delay to occur. Induction of atrial fibrillation and atrial flutter. Both can be initiated by atrial extrastimulation, or incremental atrial pacing, requiring the occurrence of intra-atrial conduction delay to establish re-entry. In both arrhythmias, second-degree AV block is the rule. Intra-atrial reentrant tachycardia, atrial flutter, and atrial fibrillation, a spectrum. These arrhythmias are best considered as a spectrum of arrhythmia, that are distinguished by their atrial activity rate, and their mode of termination. Intra-atrial reentrant tachycardia can usually be terminated by a single programmed extrastimulus. Atrial flutter termination usually requires rapid atrial pacing for several seconds. Pearls of this lecture and previous lectures. If SVT is induced, any type of inducible arrhythmia is possible, while non-inducible arrhythmias are excluded. If SVT is non-inducible, non-inducible arrhythmias are more likely, while inducible arrhythmias cannot be excluded. If SVT is readily inducible by ventricular pacing, most probably AVRT, much less likely AVNRT, rarely AT. If SVT is easier to induce from one atrium than the other, it suggests a bypass tract at that side. Atrial stimulation can induce AVNRT, AVRT and sinus node reentrant tachycardia, with no need for intra-atrial conduction delay, but such delay is needed for induction of atrial tachycardia, atrial flutter and atrial fibrillation. Demonstration of dual AV node physiology is in favor, but not diagnostic, of AVNRT. Demonstration of bypass tract is in favor but not diagnostic of AVRT. If bypass tract is suspected, pace at different sites, use isoproterenol if arrhythmia is not induced, and try induction of atrial fibrillation, to assess the bypass tract risk. Pre-excitation during sinus rhythm may present as short HV, or H buried in V, or VH pattern. Unmasking or increasing pre-excitation can be achieved by slowing AV node conduction, without affecting bypass tract conduction, using carotid sinus massage, AV node blockers, or atrial stimulation. Failure of atrial stimulation to increase the amount of pre-excitation does not exclude the presence of a bypass tract. With retrograde conduction over the bypass tract alone, the VA conduction time is constant, since there is no decremental conduction in bypass tracts, except rarely. Indicators of a retrogradely conducting AV bypass tract are: 1. Eccentric atrial activation sequence after ventricular stimulation, 2. Atrial activation by his synchronous ventricular extrastimulus. Failure of his synchronous ventricular extrastimulus to stimulate the atria does not exclude the presence of a bypass tract. Decrease of SVT rate when bundle branch block develops is diagnostic of orthodromic AVRT, mediated by a bypass tract ipsilateral to the site of bundle branch block. AV response following entrainment of SVT with ventricular pacing practically excludes AT, while AAV response is practically diagnostic of AT. Biatrial activation time in focal atrial tachycardia occupies less than 50% of the cycle length, but occupies around 90% of the tachycardia cycle during atrial flutter. Thank you.